So it's my honor and privilege to introduce Dr. Anthony Zietman as the 2015 ACRO Luther Brady Lecturer. Dr. Zietman is very well known to most in the field of radiation oncology and has emerged as a veritable legend in our field. Dr. Zietman is an expert in the management of GU cancers and is widely published in the field with over 200 manuscripts published, and many of these manuscripts have been practice-changing. He rose to the rank of full professor at Harvard Medical School back in 2003. Over the past 20 years, he has shown a strong interest in training and mentoring junior faculty, residents, and fellows, both locally as well as nationally. In 1998, he became the director of the MGH Radiation Oncology Residency Program and is now associate director of the combined Harvard Radiation Oncology Program. Nationally, he was chair of the ACRO Annual Educational and Scientific Meeting from 2000 to 2002 and became chair of the ACRO Educational Council back in 2006. He rose to become president and chair of ACRO from 2009 through 2011. Since 2007, Dr. Zietman has been a trustee of the American Board of Radiology that oversees both initial certification and maintenance certification for all radiation oncologists in the United States. Since 2011, he has been editor-in-chief of the International Journal of Radiation Oncology, Biology, and Physics. On a personal note, Dr. Zietman has been one of the most influential figures in my professional career. When I was a resident and chief resident at the Mass General, Dr. Zietman provided me critical guidance in how to become a successful academic radiation oncologist. Correlative science and the concept of targeted therapies and personalized medicine was just back in its infancy back in the late 1990s. Many in the field felt that you could be a great clinician or a great scientist, but not both. Dr. Zietman was one of the few senior radiation oncologists who advised me to pursue my passions and view the dearth of clinician scientists in the field as an opportunity, not as a barrier. Indeed, his sage guidance has shaped my career in radiation oncology like few others, and for this I will be eternally grateful. And with this, I introduce Dr. Anthony Zietman, who will be discussing the evolution of specialties, where medical specialties come from, and how they live, die, and change. Anthony. Got a little something for you, Anthony.
They give the certificate ahead of the talk these days. Well, it's a great pleasure and a great honor to be here today. And I'm going to talk about what's been on my mind for recent years. I was given free license to talk about anything I liked. So this is a talk that I've also given to diagnostic radiologists. I gave the RSNA as a major oration last year. So I'm trying to bring radiation oncologists and radiologists together with my current thinking. It's a unique honor to be giving, in particular, the Luther Brady Lecture. This picture is not Luther Brady, you know that. It's another great man, Charles Darwin, who Luther, I have to say, has a better beard than you. But not a better intellect, that's for sure. And we're going to talk about the evolution of specialties. Why are we going to talk about this? Because I think our specialty is facing some uncertain times in the future. All specialties are. And we're going to have to adapt. If we think that our current patterns of practice will do us for the future, we are wrong. And we're going to have to make some hard decisions in the years ahead. And I'm going to suggest one way in which we might evolve. So let's begin with Dr. Brady. And we're going to start here because we're going to go back and we're going to look at the history of radiation oncology as a unique specialty. And actually, Dr. Brady's career spans the entire development of that specialty. And I went back and I had a look at his publication list. And as you look at the publications going from the 40s to the 50s, to the 1960s, 70s, 80s, through to this century, you can see the evolution of our specialty. He begins with papers on radiographic diagnosis because that's how he was trained in addition to therapy. We learn more about radionuclides and supervoltage therapy in the 50s. He's publishing a great deal on manual techniques, brachytherapy in particular, but you're going to see how that becomes very important later in my talk. And then in the 60s and 70s, he was writing about outcomes before outcome science was a science. And that's very important because he foresaw what it would take to maintain radiation oncology's place in the armamentarium of cancer therapies. More recently, he's been thinking about advanced techniques, and in particular, stereotactic ablation. So his career has, I won't say mirrored the evolution of radiotherapy, because to some degree he pushed it along. And he's always been a forward thinker. I am prepared to bet that if he is still practicing on his 100th birthday, and I wouldn't bet against that, he will be thinking about where radiation oncology should go next. And I suspect he will come to the same conclusion as I have. So we're going to look at medical specialties, and we're going to ask some tough questions. What is it that makes some specialties endure? How do they adapt? What gives them strength? So we're going to start off by looking at where they come from. And originally, they were just barber surgeons and physicians. Now there are dozens of specialties. So where do they come from? How do they evolve? Then we're going to ask, where did radiotherapy come from? And then we're going to look and see how radiotherapy adapted to what I call the first great disruption in the 1960s. And they did adapt. Radiotherapy did adapt. And then in the noughties, that's what the British call the first 10 years of a century. They're called the noughties, all those little zeros, the noughts. We faced the second great disruption. And in the second decade of this century, the teenies, as they're called in Britain, we face the third great disruption. And the question is, how will we adapt to these? So let's start with the origin of specialties. It's 150 years since Darwin wrote his famous book. And I think a lot of the concepts which he developed have really become commonplace in our thinking and commonplace in our language. And they're very useful, very instructive as we think about specialties. It's not just specialties that change, doctors change. If you go back 500 years, it was bloodletting and leeches. And then by about the 18th century, we got into advanced diagnostic techniques. We were tasting urine and sniffing stool. Then down the bottom right panel, you'll see the physician of my childhood, the family physician coming to visit you at home, patting you on the head and telling you you had mumps or measles. That's the way it always was. And then the hospital clinic doctor with his stethoscope slung around his neck. And finally, a doctor standing in front of a robotic console. This is an extraordinary evolution. And actually, the biggest evolution is that the doctor, he, is now most likely to be a she. So there have been big changes. Times change, the science changes, the technology changes, patient demands change, and we have to adapt. Now these pictures describe the branching evolution of finches on the Galapagos Islands, and these come from Darwin's original sketchbooks. But they could just as easily describe the development of physicians, with the physicians on the right and the barber surgeons on the left, leading to the multiple specialties we have 200 years later. And when we think in an evolutionary sense, we have to think about adaptation and the different kinds of economic catastrophe that can face us. Or not economic, evolutionary catastrophe that can face us. In the top left, of course, we have the dinosaurs. Where they went, nobody knows, but nobody knows where they are now. They've gone. Was it a great environmental catastrophe, or were they simply outrun and outcompeted for food by the nimble mammals? Down at the bottom, you have Neanderthal man. Also, he lost out during the Great Ice Age. Simply wasn't smart enough compared with Homo sapiens. He probably didn't know how to skin an animal during the Ice Age and wear a fur coat. Probably didn't know how to light a fire. That won't do. And then, in the top right, you have an example of sort of environmental catastrophe. The dodos were indigenous to Mauritius. As everyone knows, they flourished in Mauritius. They had no predators whatsoever until the 1600s, when British sailors arrived. The dodos came down to the beach to greet them, friendly birds that they were. The British sailors saw nothing more than a big turkey dinner and clubbed them to death. And within 50 years, there were no dodos left. No time to adapt for them. So let's think of specialties in evolutionary terms. And I categorize them two ways. There are specialties with intrinsic strength and specialties with intrinsic frailty. Those with intrinsic strength, I believe, are those that essentially own a portion of the body. Urology, ENT, cardiology, gynecology. They can adapt to the new technologies relatively easily. The specialties with intrinsic frailty are those which are organized around the principle rather than geography. It's the tracer principle for nuclear medicine. It's imaging for diagnostic radiology. And for radiation oncology, of course, it's therapeutic radiation. And it assumes that a deep understanding of that science is necessary to use that particular modality, whether it's diagnostic or therapeutic. Now, many specialties panic about dying, and every specialty has its Jeremiah. I've got many, many examples of this. This just happens to be an editorial in the New England Journal from 1973. Neurosurgery may die is the melodramatic title. And what they foresaw was a specialty that was being outpaced by minimally invasive techniques, including radiation, and that was too busy operating and not having time enough to develop its own science to underpin everything that it did, and its own outcomes research. As it happens, that did not come to pass, and like many of these prophecies, neurosurgery remains very healthy. Specialties adapt. Urology, gynecology, cardiology, those that own a portion of the body can adapt very easily. And probably the most adaptive specialty that I know is urology. And I have a colleague, a urologist at the Mass General, who describes urologists as being like cockroaches. But he means it in the kindest possible way. He means that, after a nuclear holocaust, when everything else living has gone, the cockroach lives on because it can eat just about anything. So it has proven for the urologists. There's been all kinds of climate change for them. Back in the 70s and 80s, when I was a medical student, doing a TURP, crushing stones and taking off testicles were what urologists did. But reimbursement went way down on the TURP, but it didn't matter, because like manna from heaven, the radical prostatectomy was delivered, and they just switched to an alternative food source. Radiology challenged their stone management. Interventional radiologists were looking to do the endourology. They simply controlled the referral, simply didn't refer them on, and did the endourology themselves. And the LHRH agonists threatened the orchiectomy, so they just gave the agonists themselves and charged. And you all know the great LHRH agonist scandals of the 1990s that finally were settled in a federal lawsuit for $800 million in 2003. In the 1990s, brachytherapy, and I remember vividly the excitement of brachytherapy, which was going to put an end to the radical prostatectomy. But it didn't, and actually, the urologist just moved in and took over brachytherapy, keeping a radiation oncologist along to sign the prescription. And there are many, many other examples. If you look at this latest decade, prostatectomies were threatened by IMRT. What do? Well, you know what they do. They own IMRT centers. 20% of urologists do. And the robot, of course, gave them a whole new sort of lease of life. HIFU, cryo, radiologic procedures, they do them. Active surveillance. This is a huge windfall. Something that you really would think might undermine urology doesn't, because they do the rebiopsies frequently, and they own their own PSA labs. It's really quite extraordinary. They retained control of all major procedures. They took control of all lesser or minimally invasive procedures, and they asserted control of all medical aspects of GU disease. I actually take my hat off to them. I think it's extraordinary. So, you can be like a nimble mammal, which is what they are, perhaps a little carnivorous mammal. But there are some specialties that are lucky enough to develop such large knowledge bases that they have to branch. It's impossible for one practitioner to do it all. And medicine and radiology are two very good examples. So internal medicine, which was a single board a long time ago, now has 19 in total. Adolescent medicine, sleep medicine, heart failure, all the rest of it. And these are unique specialties. Radiology, of course, is multi-branched, and the branching began a long time ago. And the latest addition is interventional radiology, which is now a unique specialty in its own right. But specialties don't always adapt. They don't always branch, and sometimes they die, or at least they wither. And it's not always forward progress. Syphilology, where are you now? One of the original 4-member boards of the American Board of Medical Specialty, dermatology and syphilology, no longer. Last certificate given 1955, shortly after penicillin was discovered. Family practice is in a very, very poor state, underfunded, under-recognized, an incredibly important specialty. And it's reached such a critical state that even with new incentives that are being developed, it's not clear that enough medical students are going to be attracted into family practice to save it as a specialty. And there comes a particular point, it's like cod in the North Sea, that the stock numbers drop. And then there comes a particular critical point when male cod can't find female cod. They're just too far apart. And then, of course, the numbers completely collapse. And that's really what we are getting close to in family practice. Probably nurse practitioners are going to have to fill the void. Nuclear medicine in a very parlous way. And most extraordinary of all, although I think it's going to reverse this, is cardiac surgery. And why do I say extraordinary? Because when I was a medical student 35 years ago, the cardiac surgeons strode the corridors like colossi. They were the great surgeons. They were the most respected physicians in the hospital, certainly in British hospitals. And I think the same was true here. Great personalities. But since then, it's all been downhill. You know, they've been a big, big target. There's been a stepwise erosion of their fees. They have the burden of training in 2 specialties when they just practice in 1. But most importantly is the emergence of the interventional cardiologist. An upstream specialty, cardiology, has put a dam in the river. And they, of course, are at the end of the referral chain. And they are writing apocalyptic editorials in their own journals. You know, cardiothoracic surgery, dying star or supernova. But they are really feeling this existential threat. And if you look at it, it's for real. Coronary artery bypass grafting, down by 1/3 over a decade. Stents doubled to over 1 million. And their problem was that they defined themselves through the median stenotomy. And they did not take control of some of these vascular maneuvers. And their income, this is inflation-adapted income, has declined by over 50% over the last 20 years, and the cardiologists has gone up by about 40%. And if you look, those lines crossed a few years ago. They've actually flattened this year. I will tell you, they're much closer than they used to be. But if you were a medical student choosing a residency, which would you choose? And speaking of medical students, they are the canaries in the coal mine. No one has the most to gain and the most to lose from the health of a specialty than a medical student choosing their residency. They're going to practice in that specialty for 35 years. So they better get it right. And they're always sniffing for faint traces of noxious gases. And actually, an extraordinary source of information is National Residency Match Program data. And each year, they publish the match data, which makes for fascinating reading. So, can specialties die? Let's consult the canary. Well, in 2012, there were just 75 applicants for 120 national residency and fellowship places. Now, that has changed a little over the last 2 years. It's a little bit healthier than that. And many of those were not US graduates. But things are precarious. I believe cardiac surgery will survive. I don't doubt that. There are talks of a possible divorce from thoracics, direct entry from internship. Now, an entente cordiale is being struck with the cardiologists over transcatheter therapy because the cardiac surgeons still own one thing that the transcatheter therapists do need, and that's the pump. They need it for some procedures. So there's a negotiation going on. And most importantly, they prove that we still need them. The cardiothoracic surgeons were in early on registries. They were doing registries in the 1980s when we weren't even thinking about that. And the Society of Thoracic Surgery residency documented the benefits of the coronary artery bypass graft. The other reason they will survive is because we need them. Heart transplants still have to be done. Transcatheter therapies don't always work. Patients get endocarditis. There are failures. But I think looking into the future, training is going to change. And it's likely that cardiac surgeons and cardiologists, particularly those with an interventional mindset, will have shared modular training within heart institutes. At the moment, we're divided by departments, but in the future, within institutes. And they'll ultimately be privileged for what they do and not just for a title, the certificate. And we'll talk about that more. So now we've shown that a major specialty can really face an existential threat. It's time to think about our own. So the history of radiation oncology is very well known to all of you here. And it began at the turn of the last century, when the 19th century became the 20th. And for the first 10 years, it was just apparent that radiation could be used to eradicate superficial cancers. It then became apparent, the work of Coutard and Strandquist made it clear that actually radiation can be artfully delivered. There's a biology behind it. You can fractionate, you can spare normal tissues, you can use it in a way that hadn't been thought of by those who were first using radiation, mainly surgeons. And in the United States, the radium banks through until the 1920s were indeed controlled by surgeons. But as radiation therapy, particularly external radiation therapy, became more sophisticated, kilo, ortho, megavoltage, it clearly required dedicated training and expertise. And the surgeons had enough on their plate, and this was handed off essentially to radiologists. The ABR was formed in 1934, and right through until 1971, it was giving a dual certificate, diagnostics and therapeutics. And all you had to do was 9 months of training in therapeutics. That was it. And then you were licensed there. You had a certificate to practice. There were, however, by the 1950s, and Dr. Brady was one of those, by the 1950s, there were some true radiation oncologists. They were not practicing diagnostics, they were exclusively therapists, and they just felt that the core knowledge required to practice therapy was too great to have this sort of amateurish double training, which simply didn't respect the art of radiotherapy. They were holding informal meetings at the RSNA and the American Radium Society. There are some legendary meetings at Barney's Steakhouse in Chicago. And I have this picture which ACRO were able to find for me. I think it's the 1956 meeting. Dr. Brady, I don't think you're on this image. I blew it up and I didn't see you, but I'm sure you were at many of those meetings back in the 50s. By 58, the American Club of Radiation Therapy was formed. The club was formed, and not just the club, the residency. A unique residency in radiation oncology was developed by Del Regato in Colorado Springs, at the Penrose Cancer Center. And he really set the pattern. That was the first program. Many others followed, as you know. Residency programs developed. The club became ASTR, and by the 60s it became ACRO. Our specialty had its own specialty society. It had its own journals. Dr. Brady and Phil Rubin formed the Red Journal in the early 1970s. By 1971, it had its own certificate under the ABR and its true independence. Let's take a look at Britain, because they took a different path. Not initially, but later. In 1935, the British Society of Radiotherapists formed as a bud from the radiographic mainstream, quite a few years before the United States. And there was an amalgamation of these two branches, diagnosis and therapy, under the Faculty of Radiologists, later the Royal College. And so even though they've been apart for 70 years, they still run in parallel under the Royal College. A bit the way we run together with diagnostics within the American Board of Radiology. In the 1950s, 60s, and 70s, the radiation oncologists were the cancer clinicians. They were the ones who understood behaviors of tumors, patterns of spread. They could often diagnose radiographically. They performed many procedures in the operating room, as well as external beam radiation. But then we had the first great disruption. This was the appearance of medical oncology. This is Sidney Farber, who was actually a pediatric pathologist. And in the 1940s, he used aminopterin to treat leukemias in children. I mean, I don't know what right a pathologist has to be treating children with chemotherapy, but that's the way it was. He was a very passionate advocate for systemic therapy, as I understand it, I've never heard him speak, but a very dynamic speaker. He was a great showman. He was a great self-publicist. He had the Variety Club of Boston on his side, the Jimmy Fund, the Emerging American Cancer Society. And he believed in a world in which all cancer would be treated with systemic therapy, and in which radiation and surgery, for which he had very little regard, would be extinguished. And he caught the public imagination. And he was buoyed on, in addition, by great strides in the 1960s in the lymphomas and later in testicular cancers. So, in the United States, radiation oncologists were like dodos on the beach, to get back to our original sort of conceit. But they weren't clubbed to death by the arriving medical oncologists. They adapted. They ran into the forests, and actually supported by a payment mechanism that really endorsed the use of technology, they became a much more technological specialty. And I think by this century, we can describe ourselves as an image-centered, targeted therapy specialty. That's what we are. Now, in Britain, it was very different. So, 50s, 60s, and 70s, radiotherapists were the cancer clinicians. In the 1980s, 70s, and 80s, along came systemic therapy, but instead of running into the jungle and following billing codes, they simply, like urologists, they just incorporated systemic therapy into their own practices and became not radiotherapists, but clinical oncologists. Medical oncology did not develop until the 80s and 90s, and then it's a sort of small academic side branch of medicine. It really isn't a dominant specialty the way it is here. And at this very time, in 2015, radiation oncologists remain clinical oncologists, giving systemic therapies. So adapting to the first great disruption, in the US, we abandoned systemic therapy, followed the billing codes into technology, and are in a precarious position because are becoming a little bit of a service specialty. We don't want to be this. We think of ourselves as physicians, but there is a risk that this is how we will be perceived. In the UK, they followed their ideals of complete care, but also Mrs. Thatcher was developing private practice on the side, and systemic therapy was where the money was, not radiotherapy. So they followed a path into systemic therapy. There is less emphasis on technology in Britain, and thus they are generally behind us. And also, as you can imagine, they're a very overstretched specialty. Imagine giving systemic therapy as well as practicing radiotherapy. So where does this leave us? And those of you who used to watch Batman in the 1960s will remember Monday night, every episode was divided into two. There was Monday night and Tuesday night. So Monday night, Batman was usually left at the end of the episode with the jaws of the Iron Maiden closing on him. And on Tuesday, you learned how he got out. But on Tuesday night, little Jewish boy in North London, I had to go to Hebrew school. So I never found out how Batman escaped. So we're going to take a break. We'll find out later. The second great disruption was imaging. And what a positive disruption this has been. No one can doubt that our practice has been improved by imaging. Accuracy, efficacy, safety. It's been quite remarkable and quite wonderful to watch. And we've been in a very good position to take advantage of this, more so than the British. But out there on the corner of our field of vision, it has led to the rise of a new and potentially competitive specialty called interventional radiology. So where did this come from? Let's have a look at interventional radiology. It began with Werner Forssmann, who was a German cardiology resident, who in, I think it was 1929, first threaded a catheter through his own antecubital fossa into the right side of his heart. He was fired from his residency program, and he was blackballed from German cardiology. So what did he do? He became a urologist. And in the 1950s, he actually won a Nobel Prize for his cardiologic endeavors, not for his practice of urology. He demonstrated that catheters could be inserted into blood vessels for the purpose of diagnosis. So dye could be injected. Charles Dotter in Oregon in 1962 took this one step further. He passed the catheter through a stenosed femoral artery and proved that it could be used therapeutically. And from then on, they haven't really looked back. They are now a mature specialty, officially having their own residencies as of 2014. They are riding the minimally invasive wave. Fantastic. Good luck to them. They have their own societies, their own journals. So what's the problem? Well, there is a problem. They are facing an existential crisis too. There are two major components to interventional radiology. There's vascular intervention, but that's a victim of its own success. The upstream specialties, who are they? Cardiologists and vascular surgeons, can do all these things themselves, and do. And they have moved these days much more towards oncologic interventions, ablations, cryo, HIFU, that kind of thing. But here they are a victim of their timing, because multidisciplinary clinics have been formed, but they've been formed without them. They aren't clinicians by training, that they're striving to become clinicians, but they aren't. So they've been somewhat sidelined. Which brings us to the third great disruption. Now, I'm a great supporter of healthcare change, but whatever form it takes is going to hurt. We all know this, because we're moving from an old system where we are paid for the procedure to a new system where we are going to be paid for the outcomes we produce, for the good we do to patients. And that's going to dramatically change our thinking and the structures in which we operate. The days of a Department of Radiation Oncology, a Department of Cardiac Surgery are probably going to slowly come to an end. We will be working in integrated practice units, heart centers, cancer centers, and our allegiance will probably be more to the cancer center chief rather than the department chair. It's just coming. And it's all going to be organized around the episode of care, and the value of what we do is going to be assessed longitudinally through the care cycle. And it will be related to the outcomes we achieve. So at the moment, we have a legacy practice taking place within legacy structures. And I actually think to some degree the old specialties may longer make no sense at all. Now, I've shown this Venn diagram image already, the way cardiac surgeons and cardiologists are looking to actually share some of their training. You can have modular training in which a cardiac surgeon can learn interventional techniques. And an interventional cardiologist can learn some limited surgical techniques. All of this is possible. And we'll be privileged not for the certificate we get from, on the day of our graduation from residency, but we will be accredited for what we are trained to do. So, within this hostile environment of the third and the second and third great disruptions, where do I think we're going to go? Well, you can evolve, you can branch, you can die, we're not going to do that, or you can merge. So I've spent a lot of time on the ABR sort of thinking about this, and with the ABR with the interventional radiology trustees. There are some great parallels between radiation oncology and IR. We know there are. They are imaging-based daughter specialties of radiology. Ablative therapies are increasingly what they use, both sides. We have surgical mindsets. We think about cancer and cure. That's how we think about palliation. We think alike. The interventional radiologists, like the radiation oncologists, like the surgeons, are keeping the oral board exam because we think that tests something extra, a clinical sixth sense, which the DR, the diagnostic radiology folk, have dispensed with. And if you want to know what radiation oncologists are thinking about, just go and have a look at the journal I edit, the Red Journal. And I've gone back and I've looked at the number of times these words, image, 3D, 4D, and stereotactic, appear in abstracts in the journal in that particular year. And if you look at the word 3D or 4D, 1992, and compare it with today, a fourfold rise. If you look at the word stereotactic and compare it with today, a tenfold rise. This is our practice. This is what we do. And if you think about, let's say, HIFU or cryo for prostate cancer, they have more to do with brachytherapy than brachytherapy has to do with external beam. It's just a fact. There are huge overlaps between these specialties. And I can give you countless examples. Liver tumors, lung tumors, brain metastases, many, many things we're treating with single-dose radiation, ablative radiation. So I made a proposal at the RSNA last year. A little impetuous proposal. I don't think they were expecting it, but there we are. That's what I did. I didn't go down on one knee. But I think that these two specialties, radiation oncology and interventional radiology, have so much in common that it is possible that at least some parts of our specialty could marry. Now, there are marriages of convenience and there are marriages of love. And I think this could be both. So what does radiation oncology bring to interventional radiology? It brings a model of training, including understanding cancer. That they don't get in their IR training. They don't understand cancer. They can image it, but they don't understand it. Most of the physicists who come out of physics residencies go into radiation oncology, not into diagnostics or interventional. So we have physics. They could really do with our physicists. We have a framework of care, including evaluation, treatment, follow-up. And we have outcomes research. And this is what will save us, because we are furiously working to document the outcomes for our patients, when our treatment is beneficial, when it's not. And most importantly, we have patients. Because they are marginalized and outside the multidisciplinary clinic, they have wonderful things to offer, but they often can't offer them because they don't have access to the patients. We hold the key to the multidisciplinary clinic, the gold key. But what do they bring to us? They will broaden our portfolio. At the moment, you could argue we are a one-trick horse. More tricks. That's good. And they're actually complementary therapies. It's not very difficult to imagine using radiation with an ablative therapy. So I think there is strength to this union. It'll bring something to the patient, rationalized care. It'll bring something to the multidisciplinary clinic, which is a powerful non-surgical specialty. And both specialties can avoid marginalization. So at the moment, if you look at cancer care and think of it as a structure, surgical oncology has a very respected place. Medical oncology is a broad and central pillar. Radiation oncology is a little bit thin, and you worry that we could be kicked away. But let's say a new specialty were to emerge, and let's call it image-targeted oncology. That would balance cancer care, I think, very nicely. Same is true for Britain, where medical oncology is just a slim pillar. There's this broad, overstressed pillar of clinical oncology that's about to crumble. Well, if some of those clinical oncologists could become image-targeted oncologists, that would spread the load a little more widely, and actually, I think, make for better care. And this is not just me thinking about this. I've been speaking with Andy Adam, who is the former chair of the Royal College of Radiologists in Britain. He's an interventional radiologist. And with Liz Kenny, who's the former chair of RANSCA, the Royal College in Australia and New Zealand. And they are thinking about this very hard as well. So the strength of our union will be this sort of blended training where people lean one way or the other according to what they do in their residency and what they do in their fellowships. I actually think we've got a unique opportunity. IR and radiation oncology are both within the ABR or within the Royal College of Radiologists. It makes it a little bit easier. And there are precedents. So obviously some of the training has to be abbreviated. The IR folk don't need to learn all the vascular stuff and how to put in SPTs and drain pus. And maybe the radiation oncology folks should have abbreviated training too. We'll talk about that in a second. Now, there are plenty of obstacles to this kind of marriage. There are legacy concerns. Tradition. Whoa, tradition. Well, last time I went back to London, my medical school was just a crater in the ground on Mortimer Street, West 1. And it had been leveled because it had been fused with another hospital. The new double hospital is much stronger than either of those two hospitals were individually. So, as an alumnus, I'm sad, but I just have to get over it. It's a march forward. Self-interest. You guys will be worried about being outrun by those nimble mammals, the new graduates of these new programs. Well, I agree it's a risk. But none of this is going to happen immediately. And the interventional radiologists say, well, we're more than interventional oncology. We drain pus and put in suprapubic tubes. But actually, that's the least attractive part of the field. Most people going to IR want to be IO people. And there are training concerns. Training will have to be extended. The RRCs, ACGMA will have to approve. And then there's organized medicine's concerns. Specialty societies get all very nervous about this. And hospitals aren't organized that way at the moment, but they will be soon in cancer centers. So I believe it is the time for change. I don't believe this is the time for revolution. I believe it's the time for evolution. I believe some of the large programs, let's say Harvard, let's say the MD Anderson, should establish small pilots. And we'll see if a spark can light a fire. Let's just take, for example, an imaginary starting point. We know that radiation oncology training can be abbreviated to 27 months. That's the Holman pathway. And you can imagine a hybrid residency training. This is by year, in which they begin with an internship. They do a year of core diagnostic radiology, a couple of years of radiation oncology, one of IR, leaning towards interventional oncology, and then a final year that's sort of a fellowship that hybridizes the two. And why stop there? Make another hybrid, nuclear radiology with radiation oncology. And actually, we've done this. At the ABR, we created such a pathway for UPenn. As it happens, the individual we created the pathway for didn't choose to take us up on it. But we've shown that we can overcome a board hurdle. This was what we came up with, 16 months of nuclear medicine and 27 months of radiation oncology. A much more challenging hybrid would be to try and develop clinical oncology like they have in Britain. I'm not sure we want to go there. But there are precedents. GYN oncology being one. And you can imagine a hybrid training with lots of medicine, radiation oncology, a year of medical oncology in there. And at the end of the day, the final year will probably be focused on one area. So you'll end up a GI oncologist or a GU oncologist, but not like the Brits do, practicing across the entire gamut of oncology. So I do see a future in which we evolve, not just through branching, but through budding and merging. I believe that classic radiation oncology is still required now and for the foreseeable future. You are all safe. It's okay. But I do like the idea of new pilots, new branches coming off, emerging to create new probably initially very specialized disciplines. Clinical oncology, nuclear radiation oncology, or image-targeted oncology. Now, I don't know whether much of this will come true. I don't know whether any of it will come true. But I know that we just cannot stand still, and we have to try, and we have to experiment. And so my proposal stands, and actually we are starting to quite seriously discuss this at a board level and within some of the major programs, not just in this country, but around the globe. And this isn't about you lot. I'm not suggesting that Arnab Chakravarti go out tomorrow, pick up a needle, and try and give HIFU to somebody's liver metastasis. I'm not suggesting that for 1 second. This is not about making you into hybrid specialists. We're like matchmakers for our children. So this is about our residents of the future and trying to imagine a future in which they're going to have to practice. So this is our resident class last year, not our current resident class. And I actually sent around a little survey to all of them, 30 of them. And I said, which of you, even if it would have been an extra year or two of training, would have done a combined IR, radiation oncology, residency? And actually, 6 of them would have done it. Which of you would have done combined medical oncology and radiation oncology? Another 2. So 8 of our 30, that's a quarter, would have chosen some kind of hybrid training. And you'll notice that the likelihood of them choosing the hybrid training increased. The bottom row are the first years, the top row are the 4th years. So as they go through radiation oncology and master it, so they're more prepared to spend a little bit extra time and master something else in addition. So this is about preparing the path for our children, our residents in the future, and trying to imagine the world in which they're going to practice. So I'm going to stop there, and that's really just food for thought and food for discussion. But I think you'll be hearing more about this in the future. Thank you.
Not being a radiation oncologist, I apologize. But I was just saying, in the field of surgery, I mean, you showed the robot, and you start to see how the robot and the imaging start to merge together. And then we're asking now for intraoperative imaging. When we're using the robot, we could see a change. And I think if that starts to work, you could kind of see what the next steps are, right? I mean, we got the self-driving car that's coming and these other things. So I think some of this is coming from just the changes in technology. I think it's going to make it much easier, not just for what you described, but in other fields as well.
I totally agree. And there's some very future-oriented institution like Princess Margaret Hospital in Canada that has its own image-guided therapy center that includes radiation, surgery, IR. All the suites are together, and the physicians flow from one to another. It's a remarkable thing to see, and really very wonderful. Yes.
Yeah. Well, you had the picture of the Changemeister up there too, and one of the things that's happened the last few years with that is that many of us in radiation oncology have just seen our power and influence just fall to the ground because now the hospitals have hired all of our referring physicians, and those of us, some of us had both combination hospital freestanding practices, and our freestanding practices are just about gone because they've taken that away from us. And what would you think? In order to get this done, yeah, it would be nice if MD Anderson and Harvard did it, but don't you think on the practical side of that, in the real world, it might be maybe those of us as radiation oncologists, maybe some of the larger organizations like the 21st centuries or some of these, the advantages and the companies could get together and, form multidisciplinary cancer clinics to do exactly what you're talking about, where they bring together all the surgeons and the, interventionalists and the rad-oncs and the med-oncs into one facility where, maybe we control it ourselves so that we can also control what our patients get rather than some administrator making $8 million in an office on the third floor. And, it just...
I agree. Adapt or perish. The third great disruption is upon us.
Yeah.
Hi, Anthony. I'm not challenging you. In fact, I agree with you. But I think it's we who are at fault. We are at fault. I call myself a surgical radiation oncologist. Sometimes I call myself a interventional radiation oncologist. But we are at fault because we are giving things up. So the brachytherapists were given the interventional radiology part, the interventional, the cardiac radiation oncology, the cardiac brachytherapy. Most of the radiation oncologists did not want to go up to do the injection, and that's why the cardiologist took it over. Same thing with the yttrium-90. Yttrium-90 was ours, it was handed to us, and we did not take it.
Yes.
I had been telling many of the radiation oncologists, you have to go up. None of them wanted, very few of them wanted to go up. So in the NRC, we had to give the interventional radiologist the permission to do the yttrium-90. When it was totally ours, we just gave it away. And now, yttrium-90 therapy in many places, in fact most places, are being done by the interventional radiology. So not only are we not going and taking over other things, but we are giving up things that are ours, and it is very dangerous for our
I agree
profession.
with you. Our scope of practice has narrowed dramatically over recent years. Partly it's to do with where the billing codes lay, and partly it's due to our own timidity and desire to lead a certain lifestyle. And there are consequences to that, and we're facing them now. Yes.
Wonderful, wonderful keynote lecture, Dr. Zietman. I know this has been on your mind for a while because in 2010, when we did Tim Williams' presidential symposium on the future of oncology, you raised this exact proposal at the Future of Oncology education session. And so it's a proposal that you've made before, and I think it's wonderful, and I've been thinking about it over the last 5 years. What keeps nagging in my head is that we've seen so many instances in our specialty, and admittedly, my perspective is much more limited than yours and certainly Dr. Brady's, but endovascular brachytherapy comes to mind, all the different brachytherapy sites, skin, GYN, urology come to mind, where, as Dr. Nick said, we've had so many opportunities, and they've all, or a lot of them, have been lost. Instead of changing the entire structure of our residency program and combining residency with literally other specialties, what about the idea of teaching ourselves and training ourselves to collaborate better with our other colleagues? We're best at the radiation component. They're maybe best at the GYN or interventional component. And when reimbursement structure and bundling changes to remove the disincentives, will we be ready to actually work as radiation medicine physicians side by side in that IR suite or in that surgical suite with those very different specialties in multiple different domains of the body that we cannot predict at this point?
I agree with you entirely. My proposal is not a short-term solution. Yeah. This is just an evolution that may be necessary for the specialty. It will help us in 10, 20, maybe 30 years' time. Short-term, we have a much bigger problem, and you've really touched on this. And that's a huge and separate discussion.
Thank you.
I would like to make a couple of comments. In my opinion, I think our specialty is alive and well and is adapting very well. We are doing things like stereotactic treatments that are proven to be very effective, that compete in equal terms with surgery, many indications, with the huge advantage of being cost-effective. The second comment is, in my opinion, in the future, the access to medicine is going to be controlled by the primary care physicians. And they're going to be looking very carefully at the cost.
I agree on both those points. There are areas in our practice that are extraordinarily thriving and prosperous at the moment, and stereotactic radiotherapy is certainly one of those, in the treatment of metastases. But it's going to be a big shift. You know, there's some real existential threats to portions of our field. I don't mean head and neck radiotherapy. I don't mean thoracic radiotherapy. But big, you know, prostate cancer radiotherapy will likely lessen in the years ahead. Breast radiotherapy may diminish. You know, you all know the huge debate over the Target trial in Britain, which is radiation given by surgeons intraoperatively, and that will explode in the most volatile correspondence, which you will see in the Red Journal in August.
Great talk, Anthony.
Thank you, Jason.
As you mentioned, your proposal is more of a long-term one,
Yeah.
and you did take your head off to the urologist, the cockroaches. I mean, they're malleable and moldable, and they adapt and they consume. Should we be doing more of that in the meantime? Should we be taking ownership on more targeted approaches to therapy, on targeted therapies, i.e. systemic therapies, on other concurrent therapies with radiation? Should we be a little more aggressive as a specialty in the meantime, like the urologists, because the urologists have grown?
Yes, I obviously agree with you. And Jason is raising the possibility that one could expand one's practice. So, for example, we give prostate brachytherapy, you know, template-based transperineal approach. The urologists have come to us to ask us if because we're good with the ultrasound and with the template, if we'll do prostate biopsies. So we do prostate biopsies. We tend to do a lot of systemic therapies, do all our own hormone therapy, and we're all authorized users. We could give the radionuclides. We really shouldn't be contracting our practice. We should be expanding it. And that, I think, is part of the short-term solution.
One last question.
Hi, I'm Brady Page from Wake Forest. Thanks for an amazing talk. That was fantastic. As a recent trainee myself, I can say that I would be really excited to learn some techniques to bridge those gaps that we all know exist between us and interventional oncology type techniques. And one of the things that I was excited about to learn, a recent development in IR was a specialty of interventional pain service from IR. And I thought, wow, I would love to learn some of those things, and maybe we can generate some head-on clinical trials that just don't exist right now. Maybe we do need those combined modalities to come together, and maybe, so therefore, I think maybe proposing even another little branch of interventional pain oncology type, I think this is all exciting. Thank you.
Absolutely. I agree with you entirely.